Low-risk MDS do not have a high propensity to develop AML or to progress. They may have a very long survival, but the main problem of this kind of diseases is that they have transfusion, they develop or they have from the beginning transfusion dependency, especially for red blood cells, so they are anemic. The majority of these patients are anemic. Usually they are treated with the ESAs, so erythropoietic stimulating agents. After different period of times, but I would say a couple of years, they lose response. And when this is done, there are not many alternatives for these patients who become transfusion dependent. There are some drugs that are very promising in this sense. One is luspatercept, that is a ligand trap for activin ligands and blocks the TGF-beta pathway intracellularly, therefore releasing maturation of the erythroid progenitors, especially when the block is a late block, as in many MDS. Now, this drug that is given sub-Q every 3 weeks has shown a very high success and activity in patients who have an MDS with ring sideroblast. That means that almost 38% of patients do have transfusion independency longer than 8 weeks after this treatment, which is very good news for patients who receive so many transfusions in a month. And again, the patients who did not become completely transfusion dependent within this phase 3 study called Myelodysplastic, they do have in 50% of the cases an improvement, an hematological improvement. So anyway, also possibly an improvement in quality of life. So that's something that it's really supporting the use of this drug for ring sideroblast MDS. There is a study going on in this very moment that is comparing ESAs to luspatercept in patients who have a new diagnosis of transfusion-dependent MDS. We will see the results. Another very important drug, I think, that has to be checked upon and followed is imetelstat, complete different mechanism of action. That is an inhibitor of telomerase and is a drug that is used IV once a month. The phase 2 study that has been presented here at EHA shows a 42% overall response rate in terms of transfusion independence more than 8 weeks. But there are a group of patients who have a long duration of transfusion independent, more than 24 weeks. That is 1/3 of the total population. So again, this is a phase 2, and the phase 3 randomized trial is going to start. So we possibly will have very new approaches for this lower risk as well. And supportive care is improving, but we have to take care that every single patient with lower risk MDS has to be studied very carefully, re-evaluated for presence of somatic mutation, not only at diagnosis, but also when they lose response to any treatment, so in this case high and low risk, to decide whether this patient could be prompted to receive a transplant or earlier transplant if they have a mutation that are bringing bad prognosis, or otherwise receive target drugs and targeting agents.